We'll get started. So welcome everybody. Thanks for joining Chair's Grand Rounds today. I'm Mark Crowther. I'm the chair of the department. I'm going to apologize in advance. I've just realized that the internet connection in the room that I'm in at St. Joe's is not very good, so I'm going to, and may drop, and I hope not. Today's presenters are Dr. Bernice Downey and Dr. Jillian Roberge. I think Dr. Downey is known to everyone. She did rounds not that long ago. Bernice is the newly anointed Associate Dean for Indigenous Health in the Faculty of Health Sciences, and probably doesn't need further introduction. And Dr. Roberge is a PGY5 in our emergency medicine program, a Métis woman, and who will be joining us as a clinical scholar starting on July the 1st. And today, Dr. Roberge and Dr. Downey are going to present on Indigenous health inequity. And I know they've got a lot to say, so I'm not going to talk any further. I'll just mention again, as I do every week, that the question and answer session is open. If you have questions, please post them in the question and answer session. If they can be answered during the course of the webinar, we will answer them directly. The chat function is turned off and anonymous comments are turned off too. So if you want to post an anonymous comment, you cannot, as far as I know. And so you have to post it with your name. So thanks everybody. I'll turn it over without further ado to Dr. Downey and Dr. Roberge.
Ani, good morning, everyone. Thank you, Mark, for the introduction. Thank you, Jill, for joining me again. We're becoming quite the tag team. And I'm very happy to be here this morning. Hopefully the technology gods will be gentle with us. I do sometimes have some trouble with the internet, but I'll turn it over to Jill if that happens. So you see there the land acknowledgement that the department has been using with some formality. And I like to point that out to folks. I think it is definitely a gesture of reconciliation, taking that kind of approach. It has become at times a bit of a subject of controversy because it can feel quite tokenized. I've had many discussions about this, and so I encourage people to, when you use the land acknowledgement, to also reflect on what it is that you're doing. How have you integrated the truth and reconciliation calls to action, or some understanding, some reflection of what you've learned regarding Indigenous health, and what are you doing to integrate that into your practice? Or, are you assessing the need for more education, and that's why you're here today? So good to have the gesture, but also to take some action as well when using it. And so I don't really have too much more to say about myself. I do like to acknowledge my Indigenous heritage, and for the most part, I grew up in Haudenosaunee and Anishinaabe territory, but my people are from Lake St. Martin, Manitoba, and Dauphin River, Manitoba, and that is Saulteaux, Ojibwe, and I also have Celtic roots as well. And I'm a medical anthropologist, and I was a nurse for many, many years with focus on mental health and addictions. My research is in, I'm cross-appointed between the Department of Psychiatry and the School of Nursing, and I hold a research chair from the Heart and Stroke Foundation and CIHR on Indigenous women's heart and brain health. And so I'll turn it over to Jill in case she wants to say a few words.
Tanshi, Jill Roberge de Chinakachon, I am la femme Métis Wia, li territoire Kayesh Kakitutamik, le River Rouge d'Oshin. Hello, thank you so much for having me today. As Bernice said, I'm a Métis woman from the traditional territory of the Red River Settlement. I'm also from Manitoba originally, and I am a fifth-year resident. I'm 6 weeks today from my Royal College exam, so this is a nice break from trying to come up with mnemonics for systemic effects of lightning strike.
Okay, thank you, Jill. All right, so without further ado then, I did want to just share a short story with you. And I'm very appreciative of Mark asking me back so quickly, even though it came up very quickly too. because I think I said in my previous grand rounds that it's very challenging to try to convey all that needs to be discussed and to educate en masse with so much information. And I may have explained that I no longer try to do that because my presentations just end up too long and there's too many things to convey and people feel overwhelmed by the material. So I really have taken the position that in that, again, that reconciliation approach, the self-assessment for educational needs and you know, initiating that education is an important part. But I was happy to come back today because it does give us another opportunity, and the topic that we chose today is more applicable to the clinical practice work. So as healthcare practitioners, this is an important issue that we want to talk about. And so my little short story is that when I first graduated from nursing school many, many moons ago, I couldn't get a job in Canada. And that was government cutback policy at the time, which repeated that cycle again about 15 years later. And so I went down to New Orleans, Louisiana. And I chose that area because they came to Canada and recruited several major cities. And I didn't have to rewrite my exams, Jill. So I thought that was a bonus, and that's where I went. So during that time, there was the culture on my unit was that RNs were white and LPNs and nurses' aides were Black. And I adjusted to that situation. It was very challenging. I felt I was not racist. I embraced everyone as a colleague, and I quickly learned that I better try to fit into the system. And that was that there were very clear racial lines of division. And so I just accepted that and tried to work within that environment, but learned a lot about myself and about that system. And the second part of that little story is that while I didn't really understand it, the experience that I had taking a bus ride down into the inner city to get my driver's license. And I was reading away and I looked up and I looked around and I realized that I was the only non-Black person on the bus. And it caused me to pause and think about what that meant as an individual, you know, as to what the racial divide was in the city, and to feel that I stood out. And it was an uncomfortable experience, and it caused me to reflect. And so working in that environment for a few years and beginning to understand the culture and beginning to question racism and power and privilege in the healthcare system stayed with me all these years. The interesting thing too is that nobody recognized my indigeneity. I was considered white because I was not Black. And that was confusing for me too, because all of a sudden I had more power and I had more privilege that nobody questioned. And so it is in that spirit that we bring the comments today, that it's good to pause and reflect, where do you fit? You know, when you read the media headlines about Black Lives Matter or Indigenous episodes of racism in the healthcare system, you know, what do you do with that? Do your eyes glaze over and you think, oh, it's happened again, and you know, scroll past your screen? Or how do you reflect on your own role as a healthcare practitioner? And I think it's in the spirit of the In the Plain Sight document, one of the readings that we suggested, that the Musqueam elder Shane Point, his introduction there at the beginning, and he talks about how we're not in this to shame or name. We're in this to work together to address it and to, you know, hopefully achieve a different way. It's very, I can't do him justice to paraphrase it properly, but read that in the front. And it really touched me that, yeah, we're not in this to blame people. We're in this to make it better for First Nations, Inuit, and Métis people in the healthcare system and in general. So you'll see there that, on a moment, I gotta move this. So we circulated these learning objectives already, and we talked about in the abstract, healthcare practitioners needing to increase their awareness regarding Indigenous health and equity approaches more generally in clinical practice. And that the second part of that is really to critically reflect on one's own position of privilege and authority and how patient-client relationships are impacted overall. And so these were the pre-readings that were circulated. And I apologize because I think that I mentioned in the abstract Stephanie Nixon's article. And when I was preparing the presentation, I was kind of working more generally with these two, but Jill is also going to integrate some aspects of the article in her part of the presentation as well. So this First People, Second Class Treatment, I like to comment that when that was released in 2014, the Wellesley Institute, who were the publishers, reported that it was the most downloaded document in the history of their organization. It was like downloaded 5,000 times in 3 days. And that was, not surprising to me, because I think just generally the idea of healthcare practitioners or the healthcare system, having systemic racism was like a sacred cow. We want to believe that we treat everybody equally, that everyone gets the same level of healthcare services and support, and that is just not the case. And so this was really a seminal document that was released at this time in our region. The Michaela Salt case was happening, the young girl with cancer, and the tensions between the hospital and the family, and the family's personal decisions that they made to remove her from care. And this document was released, and the Indigenous scholars and the community immediately organized a symposium to talk about this issue. And then some of you may have been present at our conference on the weekend, where we again talked about anti-Indigenous racism. The other document, another seminal release here by Mary Ellen Turpel, and in plain sight. So this was a BC document that even though it's from that province, it really crosses all provincial lines. It's a national focus, really. And so now I'm going to ask you, if you don't already have the Mentimeter app, you can go to Google and download this free app. It only takes a second or two. And you can put in this code when it prompts you. And this will provide some interaction. We've got a couple of exercises that we're going to do. If you don't have your phone, or you don't want to download the app, you could also put your, some of the questions, as Dr. Crowther indicated, into the chat. And we'll Jill, if you can monitor it while I'm presenting, and then vice versa, we can do that. So I'm going to stop. Everyone has the code. You could maybe put it in the chat too, Jill. And so now I'm going to pull up the Mentimeter. Oops, thought I had it pulled up.
Bernice, I can't see the code now to enter.
Oh, okay. Okay, so it's the code is 21 18 46 1.
Okay, perfect. Thanks.
Okay, so can you see my screen, Jill?
No.
Oh, okay. So now can you see my screen? Okay. All right, so is there anybody that's having a challenge or has a question about accessing the app? Okay, so there's the first, so we have a series of true and false questions here. And so you can go ahead and enter your response. How many participants do we have on board?
67.
Okay, thank you. Okay, some people.
Hey, Bernice, I submitted mine and it's not updating. You might want to see if you refresh that to see if something happens.
Yeah, I can tell there's 14 participants. I have the answers hidden, but I'm going to unhide them now. Okay, so no debate here. We'll go to, and we'll talk a little bit about this at the end. So most of the people who answered are seeing that racism beliefs do continue to oh, okay, so next one. Racism is held in place because media and education systems perpetuate it. Okay, and I put the not sure one response option there because a lot of people really just have not had a lot of opportunity to discuss or debate these kinds of issues. And so, so this one here, you can see predominantly folks are in agreement with that. Next slide. Events and government policies from 150 years ago continue to impact Indigenous people's health in 2021. Okay, folks are mostly in agreement with this. This is true, and it's quite often an attitudinal barrier for Indigenous folks. We often hear feedback of, what happened in residential schools and colonization took place so long ago. We need to just get on with it. Why are we still spending so much time on this? And the fact is that, we have done research. There are studies that measure the intergenerational impact on family systems and dynamics over generations. And so that's just one example. But when we think about the ideologies and the systems in place, they also are important factors. Okay, racism occurs when a racial group's prejudice is backed by legal authority and institutional control. Okay, people are agreeing with this one. I think it's pretty straightforward. We see this in systems all the time. It's not until, it's not a carrot or big stick kind of option. It's mostly big stick that protects policies in place. And until decision makers and policymakers, get on board, get educated, and change policies that that people begin to follow along. We like to think that we're all well-intentioned until we try to change the system individually. Okay, so this next slide. Racism is a system which begins with ideology. Okay, had a little bit of a debate there, and I'm happy for people in the discussion to raise reflections or questions. Being perceived as white is a social and institutional status and identity that carries legal, political, economic, and social rights and privilege. Okay, not too much argument there. Contrasting how a racialized person was treated with how others were treated in a comparable situation. Oh, I'm sorry. I'm going to stop there. That pertains to the next exercise. Okay, so we're going to get out of here. And we are going to go back to the presentation. Yeah, so are there any comments or reflections on any of those statements? Okay, feel free to put them in the chat as well. So, so this is the quote from Shane Point that I mentioned earlier, is that when the other branches of our collective family think of us, there is a common perception of Indigenous peoples as being less than, less able to care for ourselves, less able to achieve, less able to advocate for the services that we need. And so that was the introduction to his perspective. And then he talked about the reconciliation work and the collective approach to changing things that we needed to adapt. And so, so this next slide is, this next part is a bit about our own experiences here. So I'm going to just stop share again, just so that we can connect facially here. So go ahead, Jill, you want to start?
Sure. I'm going to sort of tell a story that happened within our own hospital system pretty recently. So I am a Métis woman. I'm not necessarily visibly as an Indigenous person. And so I wear a lanyard that is a Métis sash that is a representation, an important symbol for Métis people of our identity to work every day. And I was at work and the allied healthcare professionals that I was working with pointed out my lanyard and said, "Oh, hey, you're kind of representing your culture." And I said, "Yeah." And then another of her colleagues was standing beside her and sort of asked, "Well, what is that? What do you mean? What does that mean?" And I said, "Oh, I'm Métis. This is a representation of Métis identity." And then I was briefly called away to deal with a patient issue. And when I came back, I was charting somewhere where I was not, it was not visible that I was back, but I was within earshot of my colleagues. And they were talking about how I don't even look Native, and that people like me getting into medical school are the reason why in this case they were saying that white men are not able to get into medical school. One person had a nephew who was not successful in pursuing getting into medical school, and this person said that because if you have one Indigenous, well, they said one Native family member, then you get automatic access to medical education. So I think that misunderstanding is a great kind of jumping off point to talk about the representation of Indigenous people in medicine. The most recent census showed that there are about 760 Indigenous physicians in Canada. And they're of the total of 93,985. So we're about less than 1%, about 0.8% of physicians and Indigenous people in Canada are more than 4.5% of the population. So there certainly is not a proportional representation. Also, there are a lot of systemic barriers that make it very challenging for Indigenous people to pursue medicine. First Nations schools on reserve, on average, receive about 15% less funding than their off-reserve counterparts. And this often is reflected in poorer quality education, which makes pursuing undergraduate university level courses very challenging. And that is reflected in First Nations and Inuit people being even more underrepresented among our physicians. I think also, I guess maybe I think that there's an associated question about sort of where this experience and this topic would fit within the stratas of racism. Did you have that on the Mentimeter, Bernice?
Yeah, so I was going to share my example as well.
Perfect.
And then we were going to go to that. So, so we both, have had conversations before, and we may have mentioned in the first grand rounds that several Indigenous health practitioners have gathered in response to the Joyce Echaquan case from Quebec. That happened and shocked the nation. Well, shocked many, didn't shock a lot of people. But in response to that, several of us gathered to talk about how we needed to address what was happening. And many of our colleagues that are engaged with our clinical partner hospitals in the region have been individually trying to address, incidents of racism, trying to work with administration and so forth. So we engaged all 6 hospital CEOs and have had 2 meetings since then. And what became clear in our conversations with them is how many of us had experienced our own incidents of racism towards us as Indigenous healthcare practitioners. And you live in that moment individually, and you almost you deflect it because you do understand it intellectually what's happening, but you often don't understand it emotionally, and so you turn it off. And at least that's how I dealt with it. And it's not until you get to talk about it a little bit with somebody, you process it and understand that is exactly what is happening. And so for me, my story was about going into a walk-in clinic on a Sunday morning because I had a bladder infection and needed medication. And so, as we do on Sunday mornings, I had my sweatpants on, no makeup, I think I combed my hair. But I looked, very casual and not like the Associate Dean of Indigenous Health, whatever I'm supposed to look like. So anyway, I went in with my symptoms and had to give a urine sample. And when that was processed, the person came back in the room, sat with me, and asked me if I'd had a one-night stand the night before because there was blood in my urine. And I was just, of course I was taken aback. I didn't show anything in my face, but I laughed and couldn't respond. I thought, how does one respond to that? And so I got my medication and I left the clinic and I felt nothing. I was numbed out. But I've told that story a few times now. And in fact, I shared it with the Hamilton Spectator when they did an article on racism. And, the first time the guy interviewed me, the journalist interviewed me, I couldn't talk about it. I thought it would be so public. And I was so ashamed that that was the response that I got as a woman. And then he called me back to ask me if I would talk about it. And that's what he printed. And because it was such a powerful statement that it doesn't matter what walk of life you come from or what kind of credentials you have, that you can experience this. And so as Indigenous health practitioners, this happens all the time. And, I don't share that story lightly, but it does drive home the fact that this does exist. And And it's not just our clients who are experiencing it or making it up. And so, yeah, so we wanted to talk, in defining racism. So I think, Jill, this is the part that I'll go to here first, just for a couple of slides on this.
Yep.
And just so that we can get through here as well. And so, yeah, so the idea was to be thinking and reflecting about what is systemic and individual racism. And so I guess I will go to the next video. Sorry, I kind of get off balance when I tell that story. Okay, so I want to go back to Mentimeter.
Just while you're setting that up, Bernice,
Yeah.
just our wonderful friend and colleague, Curtis Sobchak, just made a comment, sort of a reflection on the questions in the chat. And he was adding that he put not sure for whether the question that addressed the root of racism, as he points out that it's also created by social systems that allow these beliefs to form. So great point.
Thank you, Curtis. Okay, so the examples that you see on your screen there then, so contrasting how a racialized person was treated with how others were treated in a comparable system. Do you see that as individual racism, systemic racism, or BIPOC racism? Okay, so you can see a bit of a debate and probably some overlap factors here as well. All right, so we're just, we're going to go to the next one. Oh, geez. Okay, so exclusion from formal or informal networks or opportunities, neglecting or leaving a BIPOC individual out of communications. Okay, majority folks seeing that as systemic racism. Failing to deal with racial incidents or downplaying the seriousness of such conduct, i.e. that was not really their intent. Denial racism. Okay, so that was a bit of a trick question. I shouldn't have put denial. I was trying to make up another kind of racism. It is denial, and but it is a form of systemic racism. Okay, so I'm going to stop here and just checking for anything in the chat or anything you want to add, Jill.
Yeah, Dr. Teresa Chan made a comment that in both of our stories that misogyny was also present and that so much is intersectional.
Exactly.
Yeah.
Thank you, Teresa. And yeah, so the goal here is not to convey everything there is to know about anti-Indigenous racism or racism concepts, but we're going to give you a few things, a few concepts to consider. And of course, the readings that we provided give you a lot more information, a lot of references, and the intercultural or cultural safety training that we talk about is also another excellent opportunity to learn about racism in the healthcare system. So you can see here that provided some of the definitions that are critically important. So understanding that racism is a belief that a group of people are inferior based on the color of their skin or due to the inferiority of their culture or spirituality. It leads to discriminatory behaviors and policies that oppress, ignore, or treat racialized groups as less than non-racialized groups. It's also, you can see here that it does take many forms: symbolic, embodied, psychological, institutional, systemic, everyday, and interpersonal. And I think, you know, we chose that little exercise to define which the difference is between individual and systemic racism, because a lot of people don't believe that systemic racism does exist. And probably the most poignant example lately is the Quebec Premier, you know, denying systemic racism was present in the face of a report that was commissioned by the province, clearly saying that systemic racism is present. And so it's very important to, you know, make the connection between the two. And if racism is occurring, how is the system around you supporting it? And so this is a dilemma that our Indigenous health science students talk about from time to time, because we try to prepare them, not to the level that we need to yet, but we're working on that curriculum piece. We try to prepare them to go into clinical practice and understand you know, the need to the EDI and the racism components. But when they get to the clinical environment, the people who are around them are not prepared. And so it becomes very challenging as a student to say, I think I witnessed an incident of racism, or why is that client not being referred when this one was, you know, so it becomes very challenging. And so it's important to understand how those systems also impact the situation. Okay, and so further here, this is a comment on anti-Indigenous racism. So this is the ongoing race-based discrimination, negative stereotyping, and injustice experienced by Indigenous peoples within Canada. It includes ideas and practices that establish, maintain, and perpetuate power imbalances, systemic barriers, and inequitable outcomes that stem from the legacy of colonial policies and practices in Canada. And so when we talk about EDI approaches, this is the conversation I think that's very important, because while there is intersectionality between groups in addressing racism, for example, there's also the nuance that is needed to create approaches that are specifically addressing what happened to Indigenous people in Canada, which is very different from the experiences of other folks who face racism in the healthcare system. And so we will go now to a very short clip. Can you see my screen again?
No.
Now you can?
Yep.
So this is Justice Murray Sinclair speaking about racism.
I think you were just at the end of the clip there, Bernice.
Oh, thank you. How do I get back there?
I think if you just reload the page, or that works too.
of the TRC, there was talk of a reckoning around relations between Indigenous folk in this country and the nation itself. We've seen, the reckoning that we saw this summer over the course of relations with Black communities and the conversations around anti-Black racism. Do you believe that sense, that reckoning with Indigenous communities and the racism that those communities faced, has that come to pass? Has that been a true reckoning?
Well, we haven't seen the end of it. It's going to keep occurring because the systemic racism that is inbred into our very institutions are going to dominate the conversation for years to come. People in law school, for example, and trying to be good lawyers and trying to be humane people, to do unjust things because of the way the laws read, and so we really do need to look at changing our laws so that we can be the kind of lawyers we want to be. People who hospitals are often taught and pressured by their colleagues to behave in a particular way. And sometimes they're pressured by their colleagues to maintain silence in the face of their colleagues' blatant racism. And that's true for police officers as well. So we need to ensure that the systems in which they function are able to confront both the internal racism that's there, but also to confront its own inability or lack of willingness to deal with how it is compelling certain behaviors or allowing certain behaviors to occur without changing them. Indigenous people and people of color are standing up and saying enough is enough is one thing, but the people who control the institutions, people in charge of the institutions that we're trying to address, really do need to take stock of what they're doing and change the way they do business.
Okay, so what you see on the screen there now is a quote made by Murray Sinclair in 1988, where he said, then if you get rid of all the racists and all of the positions of government, policing, justice, health, you will still that is functioning based on based upon policies, priorities, and decisions that direct how things are to be done, that come from a time when racism was very blatant. So that was 1988. So when we think about, here he is reflecting as he retires from the Senate, that there's still such a long way to go. And so again, driving home the point that it is the systemic level that we have to get to, as mentioned by the senator. And so we mentioned ideology in the Mentimeter exercise there. And this slide speaks to the fact that we do have a very real colonial ideology, and that there is a direct line between the history and experience of colonialism and the challenges of Indigenous specific racism within the healthcare system today. I thought the In Plain Sight document really covered this connection very well. I thought it was an excellent document that really brings to the fore this particular point and really dives deep into various issues related to discrimination. But the cultivation of racist beliefs that Indigenous peoples were weak, dying off, incapable, and primitive enabled the state to enact policies to segregate, assimilate, and govern all aspects of the lives of Indigenous peoples and expropriate their lands. And the most important fact here today as well is that this is still in place. We still have racist legislation, the Indian Act, that is still guiding the work of the federal government and the provincial government. And so this is a very important point, and it's very complex. A lot of people say, well, let's just do away with it. That was the focus of the white paper in 1969 that was tabled and was rejected by Indigenous people. And the reason being is that, just doing away with the whole history and assimilating us into mainstream society is not the answer. That we are also trying to uphold our unique rights as Indigenous peoples, our right to our healthcare, and the way that we receive it, and the way that it's provided for us. And so in some way, it's a very complex issue that in some ways the legislation also protects some of our interests. And so the last point there you see that made is that those who enjoy privilege have no reason to change things. And so that's really the emphasis on the education. And so, Jill, I'm going to turn it now over to you for this clinical case study. And I think in the interest of time, maybe we won't go to Mentimeter, but encourage people to put your comments in the chat. So I'll turn that over to you now.
Okay, sounds good. So this is a case of a 60-year-old, visibly Indigenous male who presents to the emergency department complaining of persistent cough and chest pain. He arrives alone at triage and gives as his permanent address a Northern Ontario reserve community. He presents a card in his hand, which he refers to as his status card, but is advised that that won't be needed. He is noted to present as very quiet and deemed by triage staff to be resistant and non-compliant with the admission process. His previous chart is retrieved and indicates that he was assessed for the same symptoms 3 weeks ago, but missed a follow-up appointment for GymRec. He was prescribed antibiotics for a left lower lobe pneumonia at that time, but he reports that he has not filled that prescription. So in looking at this case, what are some of the factors that you can point out in this individual's case when you're sort of assessing the factors that impact his presentation? And we can just put answers in the chat.
You can also send answers individually to Jill. That provides a bit of anonymity or any questions.
So some responses here. So this was addressing. I'll sort of speak to this later, but just sort of a question about my experience hearing colleagues discussing Indigenous peoples taking spots in medical school, how I responded, and how could an ally help respond. So I will table that, and we will definitely discuss that for sure. And there is the point is made that his financial access to medications is a factor. Also his ability to fill his scripts, ability to attend a follow-up clinic appointment.
So there's likely other reflections. And Jill, if there's any other comments you want to make about it, perhaps the status card one is a good one too.
Yeah.
Go ahead, Jill.
I think just in terms of folks having an understanding of how First Nations people who access medical care, and then I think especially in this situation how they access prescription medications, because it is a parallel system, and it is the NIHB, which does not cover all medications, and oftentimes won't cover things that are not generic, for example. So in this case, it may be that the person wrote a prescription for a medication that was not covered for this individual.
The other point too I wanted to make is that I was thinking also that he might have been trying to legitimize his presentation. That, he was trying to tell people that he was First Nations, that he was from a Northern Reserve, and, to have some power in that relationship. This is who I am, and I have rights, and I can access medications with this. So he may not have said all that, but without understanding the significance of a status card, individuals, that's why they told him to put it away, because it wasn't OHIP, it wasn't anything meaningful to them. And so we tried to capture a little bit of the power imbalance, that the staff saw him as resistant and non-compliant, whereas he has had several, very negative experiences with staff. And often Indigenous peoples will avoid going into ERs or clinics because they've had previous experiences of racism. There's very good coverage of this in surveys that were done in the in plain sight process. And so he has decided the best thing to do is to be quiet and just get his medications and get out of there. And so that perception that he's non-compliant, and then of course not coming back when he was supposed to represent at the clinic. Did you want to comment on that part, Jill?
Yeah. So in this scenario, this gentleman has come down from the north to access services. However, in where he's staying now, he has unstable housing. And as we know, and certainly is the case for many of our patient population in Hamilton, folks who have unstable housing have a very challenging time being able to make an appointment, keep an appointment, being able to be somewhere where we'll often say, well, they'll call you and tell you when your appointment is. And if they don't have a telephone, don't have a secure place to stay, then that makes that incredibly challenging. Also, he is isolated. He's away from his community. He presents by himself without any social supports. So that also makes it challenging. There's no one there to support him if he needs transportation. And he may be stranded there, and it can be challenging to get home sometimes as well. And oftentimes there may not be someone who's allowed, if you're coming down from up north, to come with you. So that depends a little bit on the situation.
Okay, so we just got 7 minutes left, and Mark has already warned us he will cut us off ruthlessly. And so I just wanted to say that in our late night coordinating our show here, we have different versions, and so the screen definition of privilege is not showing here, but this is the last couple of slides. Essentially, the whole concept of privilege operates on personal, interpersonal, cultural, and institutional levels, and gives advantages, favors, and benefits to members of dominant groups. Privilege is essentially unearned and mostly unacknowledged, an unacknowledged social advantage that non-racialized people have over other racial groups. And so being perceived as white is a social and institutional status and identity. And so if for folks who have done your Indigenous cultural safety training, there is a focus on this, because that's one of the most important elements to understand, that in our exchange with Indigenous peoples, we need to, convey and adopt within ourselves a level of cultural humility. And so I think we're going to do another Mentimeter process, but we're not going to do that.
Bernice, I'll just add to that, because we were going to mention, on the point of privilege, there's a really excellent article written by Stephanie Nixon.
Thank you.
Called the COIN Model of Privilege and Critical Allyship: Implications for Health. It's a really excellent article, very well written, really, I think, effective metaphor using the idea of a coin. And so essentially each sort of oppressive situation is its own coin, such as racism, sexism, anti-Black racism, anti-Indigenous racism. And each of us may find ourselves either in a position of privilege or on the bottom in a position of a lack of privilege for different coins. So all of us likely have places where we have privilege and domains in which we do not. And so that's why it's a process for all of us to explore our own privilege and how that impacts our work. And thank you, Dr. Chan posted the paper in the chat there. That's perfect.
Yeah, that's great. And so maybe we've got 4 minutes left. We ask you to put any questions or comments that you have.
Maybe I'll answer Sonia's question that she had posted earlier. I'll just say sort of succinctly, I didn't do anything in the moment. I've had a bunch of situations where you kind of drive home and talk to yourself in the rearview mirror and say the things you're like, oh, that would have been such a good thing to say. But, it was an allied healthcare professional. And I think that impacted my comfort to speak to them directly. And also what I feel like I've done about it since is things like this. This is what I feel like, taking that energy and channeling it into being involved in things like this is what makes me feel okay about situations like that. And I do think someone sort of showing active allyship in that situation, I think it's helpful to, if they feel comfortable to kind of call it out in the moment, it can be helpful. But also just sometimes when something like that happens and someone comes up to you after and is like, that was really messed up, that alone I find can be helpful. And then kind of taking your cues from that person around what other things that you can do to support them if they want to kind of take this further.
So thank you, Jill, and for the question, Sonia. So the last couple of slides here speak to some of the interventions and training that were referenced in the In Plain Sight document and in the First Peoples second class treatment. So you see there, of course, emphasis on the cultural safety training. If you have not yet done it, I would strongly urge you to start there. It's like 8 episodes on Netflix, 45 minutes each. It's very interactive, very informative. And there are free programs that are available to you as well. If you go to the Indigenous Health Initiative website and look at our resources, there's a whole list there. Trauma-informed care, of course, understanding and beginning to engage with that kind of perspective. And you can see some other, I won't go through all of them there, but I think the emphasis on education, continuing to dialogue about this. Maybe Mark will have us back again. Mm-hmm. And so I'll turn it back over to Mark for a closing comment. Sorry for the rush. It's so much to talk about in 50 minutes.
All right, thanks guys. And thanks for an illuminating set of rounds. Just a couple things about cultural safety training to build on what Bernice just said. The department had purchased a number of the one course and we filled that. So there are 25 people in the department about to start the SANIAS cultural safety training within the next couple of months. Opportunities for that one only come up intermittently. It's very oversubscribed and it's also quite expensive. So we have limited access to that one. Cancer Care Ontario does actually have an Indigenous cultural safety training program as well that I think I've done both of them and it's also quite good. It's free. I would strongly recommend it. I imagine most of the people who are watching this webinar have actually done it, but if you haven't, I would strongly, in the strongest possible terms, recommend that you do it. It's an extremely valuable learning opportunity. I'd like to thank Dr. Roberge and Dr. Downey for their rounds today. Again, this is an issue which I think we all acknowledge, but probably don't pay anywhere near as much attention to it as it deserves to have paid to it. We will continue this discussion probably in the fall. You don't get another set of rounds before the fall, Bernice. You've had 2 of them. And hopefully good news on the vaccine front and lots of other places in the next few weeks. So hopefully when we do rounds, Chairs Grand rounds in a month from now, we'll have positive coronavirus news and also the light at the end of the tunnel may be more clearly the end of the tunnel rather than a train. So hopefully we are heading towards the spring where we get some freedom of action. Thanks, Bernice. Thanks, Jillian. And Jillian, thanks for your continued commitment to McMaster and look forward to enthusiasm with you coming on as a clinical scholar and then on faculty after that. So thanks very much.
And don't forget to come to the March 8th lecture by Dr. Nadine Caron, the first Indigenous woman surgeon. And I forget the name of the award process there, Sonia, if you're still on, but it's Monday, March 8th. And that will be an excellent story as well. Very esteemed Indigenous surgeon. Have a good week, everyone. Thanks again, Mark. Bye, Jill. Bye, everyone.
Thank
you.
That's
the Change Delaney lecture. So those of you can look up Change
Thank you.
That Sonia's right. Thanks very much. I can talk to you later. Bye now.